Hello everyone, today we will discuss gastrointestinal bleeding. So before going to the topic proper, we'll see few terminologies like upper GI bleeding. So upper GI bleeding signifies gastrointestinal tract bleeding due to cause above the ligament of Treves, which is located at the duodenal-jejunal junction or DJ flexure. So this is the ligament of Treves and this is the DJ junction or DJ flexure. So this is the duodenum and from here the jejunum starts. So this is the landmark DJ junction. So any bleeding that occurs above or proximal to the ligament of Treves is termed as upper GI bleed. Similarly, any bleeding that occurs below the ligament of Treves, so this is the ligament of Treves, so any bleeding occurring below the ligament of Treves is termed as lower GI bleeding. So the lower GI bleeding, as I have said, it signifies GI bleeding due to a cause below the ligament of Treves. So this bleeding rarely enters the stomach and therefore results in either MELAENA or HAEMATOCHEZIA. It is important to remember that any cause of bleeding in the upper GIT, if large enough, can also cause MELAENA. So next terminology is hematemesis. So hematemesis is vomiting of blood. It indicates that the bleeding is from a cause which is proximal to the ligament of Treves. The color of vomitus depends on the concentration of hydrochloric acid in the stomach. If the vomiting occurs soon after the upper GI bleed, then the color of the vomitus will be bright red. On the other hand, if there is a time lag, then it will be dark red, brown, or black in color. Change in the color is due to the interaction of blood with the hydrochloric acid to form hematine, which is black in color. Coffee ground appearance, described with hematemesis, is due to the presence of precipitated blood clots in the vomitus. Hematemesis of significant quantity will cause MELAENA, and about 50% cases with MELAENA have associated hematemesis. Next is MELAENA. So MELAENA is passage of black and tarry stool which sticks to the pan. It occurs both from upper and lower GIT bleeding. Around 60 ml of acute blood loss will produce one melanic stool. It is to be differentiated from other causes of black stool like ingestion of iron or bismuth, where the stool are black in color or darker in color, but the stool is not tarry or sticky. So besides that, we have to rule out other causes for blackish discoloration of stool when we encounter a case of MELAENA. Next term is HAEMATOCHEZIA. So HAEMATOCHEZIA is passage of fresh blood per rectum due to lower gastrointestinal tract bleeding. Rarely it occurs due to upper GIT bleed, and is possible only if the GI transit time is rapid and with less blood acid contact. Otherwise, it is rare secondary to upper GI bleeding. Massive GI bleeding. So when we'll say massive GI bleeding, when there will be acute loss of 1 liter of blood or any blood loss enough to cause hypovolemia. So then we'll say it as a massive GI bleeding. So with this, we'll start with upper GI bleeding. So coming to the causes of upper GI bleeding, so common causes are duodenal ulcer, gastritis, it can be acute, chronic, erosive or infectious, and gastric ulcer. So these causes comprises of 85% of upper GI bleed. And coming to the rare causes, we have esophageal varices, Mallory-Weiss syndrome, carcinoma esophagus, carcinoma stomach, swallowed blood, say in the form of hemoptysis or epistaxis, foreign body esophagus, or blood coagulation disorder, or patient on anticoagulants, hematobilia, pseudoxanthoma elasticum. And so these are the rarest cause of upper GI bleeding. Coming to the precipitating causes, so they are alcohol, NSAIDs or steroids, excessive fibrosis, or atherosclerosis. So these are the precipitating causes. Coming to risk stratification. So rebleeding from peptic ulcer disease is the single most important determinant of death from upper GI bleeding. The most important predictor of rebleeding are age, more than 8 years, hemoglobin less than 8 gram%, endoscopic stigmata of recent hemorrhage, comorbidities like cardiac failure, renal failure, or liver disease or liver failure. So all these factors have been combined into a risk score, which is known as Rockall score. The endoscopic identification of bleeding stigmata are important and are assessed by modified Forrest classification. So coming to modified Forrest classification, so it is divided into 1A, 1B, 2A, 2B, 2C, and 3. And in 1A, the endoscopic finding will be spurting arterial vessels. And here, the rebleeding rate is about 80 to 90%. Coming to 1B, endoscopic finding will be oozing hemorrhage. And here, the rebleeding rate is 10 to 30%. Coming to 2A, endoscopic finding will be non-bleeding vessels. And here, the rebleeding rate is about 50 to 60%. Similarly, 2B, the endoscopic finding will be adherent clot, and rebleeding rate is about 25 to 35%. In 2C, the endoscopic finding will be ulcer base with black spot sign, and rebleeding rate here is approximately 0 to 8%. And in class 3, the endoscopic finding will be clean base, and the rebleeding rate here is 0 to 12%. So this is modified Forrest classification. So coming to the Rockall risk scoring system. So attempts to identify patients at risk of adverse outcome following acute upper GI bleeding. So Rockall et al. Identified independent risk factors which were later shown to predict mortality accurately. This scoring system uses clinical criteria as well as endoscopic finding. So clinical criteria include increased age, comorbidities, shock, whereas endoscopic finding includes diagnosis and stigmata of acute bleeding. So these comprises the Rockall risk scoring system. So for memorizing, we must see A, B, C, D, E. That is, A stands for age, B blood pressure which falls, that is shock, C comorbidity, D is the diagnosis, and E is evidence of bleeding. So this mnemonic we must remember: A, B, C, D, and E. The total score is calculated by simple addition. A score less than 3 carries good prognosis, but total score more than 8 carries high risk of mortality. So this is the chart which is showing the scores: age, shock, comorbidity, diagnosis, evidence of bleeding. This is the ABCDE. And if the age is less than 60, so score will be 0. If there is no shock, score will be 0. If there is no comorbidity, no major comorbidity, then it is 0. Or if the diagnosis is MELAENA, score is 0. And there is no evidence, then the score will be 0. Similarly, when we will say the score is 1, when age is between 60 to 79, pulse rate will be more than 100, or blood pressure is more than 100 systolic, or the diagnosis is other than MELAENA and GI malignancy. And when we will say it's score 2, when the age is more than 80, or systolic blood pressure is less than 100, or there is comorbidity like chronic congestive heart failure, or liver failure, or major morbidity, or when there is the diagnosis is GI malignancy, or in the evidence of bleeding there is blood or adherent clot or spotting vessel. So if you encounter all these factors, then it will be labeled as 2. And when it will be labeled as score 3 is when the comorbidity is kidney failure, liver failure, or metastatic cancer. So we'll add all the factors, and on addition, a score will come. And so if the total score is less than 3, so that carries a good prognosis. And the total scoring, if it is more than 8, it carries high risk of mortality. So coming to the diagnosis of upper GI bleeding. So there should be history of ulcer disease or liver disease or abuse of alcohol or NSAIDs. We have to check for concurrent iron therapy or other causes of black color stool, which can be confused with true MELAENA. So examine for stigmata of chronic liver disease. Vital parameters should be checked like pulse, blood pressure to rule out hypovolemia. Hemoglobin concentration should be monitored on regular basis. Check the ratio between urea and creatinine. An increase in ratio in normal renal function suggests upper intestinal absorption of blood. Coming to the management, so bleeding may be massive and thus urgent steps are required. So management can be immediate management, it can be subsequent management, and definitive management. Coming to the immediate management, it comprises resuscitation and investigation. So resuscitation and investigation should proceed simultaneously. Approximately 85% of massive GI bleeding stop to bleed just prior to admission or after admission. On admission, always start a IV line with a wide bore cannula in one upper limb. And if the patient is in shock or if we think there is an impending shock, then a CVP line should be established in another arm. The CVP line will help in pumping fluid rapidly into the body, and side by side CVP monitoring can be performed to assess fluid resuscitation. CVP monitoring at regular interval is important for adequate resuscitation and to avoid fluid overload, especially in patients with the previous cardiac or respiratory disease. So once we establish a IV line, so blood is drawn through the cannula for tests, and after obtaining the blood for the test, IV fluid in the form of ringer lactate or plasma expanders is pumped via the IV line. So following tests are advised. Send the blood for following tests. So that includes blood grouping and cross-matching, complete blood count, hematocrit level. So serial estimation of hematocrit level gives an idea of quantum of bleeding. Besides hematocrit level, we should advise platelets or prothrombin time or partial thromboplastin time, serum electrolyte, blood sugar, blood urea, serum creatinine, liver function test, ECG, and if the patient is in respiratory distress, then arterial blood gas analysis, that is ABG analysis, should be advised. So this is the Forrest catheter which we can see. So after doing this, we must catheterize the patient with the Forrest indwelling catheter, and this is done to assess the urine output. So this is the two-way Foley's, one way, two-way. So two-way Foley's. So this is the tip is to be introduced per urethra. So from here it will be introduced, and here we can see it has gone into the urinary bladder. So once it reaches the urinary bladder, then we'll inflate the balloon. So normal saline is injected through this balloon port. So it has the capacity which is written here, the size is written here, the capacity of the balloon will be written here, and moreover there will be the color code, international color code. So that way we know whether this policy is 18 francs, 16 francs, 20, or so on, 14, and so on. So once it is introduced inside and balloon is inflated, so this inflation of the balloon prevents the slippage of the Foley's catheter. So that is why it is known as indwelling catheter. And once this maneuver is done, inflation is done, we can see the urine will start coming through this urine drainage port. So in this urine drainage port, the urobag is attached, and the urine, whatever is there, sorry, so that will come and get collected in the urobag. So catheterization is important and it should be done. So once the initial phase of shock is tackled or treated, the patient is further assessed. A detailed history is taken. Vital parameters should be checked at frequent interval. Physical examinations should be carried out, which will point to the diagnosis. For massive GI bleeding, at least 6 units of cross-matched blood should be demanded and should be kept ready. So once blood products are available, it should be transfused as per requirement. Blood is transfused till vitals come within normal range and the hematocrit level is above 35%. Next, we have the subsequent management. So a large bore nasogastric tube is passed and chilled normal saline gastric lavage can be done. So chilled saline is introduced through the nasogastric tube and it will reach the stomach, and this should be done till clear fluid comes out. Or besides that, after doing this procedure, we can use saline mixed with 1:2 lakh adrenaline also to stop bleeding. This is the Ryle's tube. So this is the tip which is introduced through the nose, and ultimately it will reach the stomach. So endoscopy is carried out to localize the source of bleeding and the site of bleeding. Subsequently, therapeutic procedures can be performed, which includes injection sclerotherapy or endoscopic coagulation. So in the injection sclerotherapy, we use ethanolamine oleate, epinephrine, or distilled water. These agents can be used as a sclerosant. And endoscopic coagulation can be performed with the help of laser, bipolar cautery, or heat probe. So this is the therapeutic procedures. So this can be also done while performing endoscopy if we localize the source or site of bleeding. Selective angiography can be done in patient who continues to bleed, and endoscopy cannot clearly locate the source and cause of bleeding. So when endoscopy fails to locate the source or cause of bleeding, then selective angiography can be done. So this can detect blood loss even at a rate of about 0.5 ml per minute. So after doing this selective angiography, if we find the source of bleeding, so that bleeding vessel can be embolized as well, and thereby bleeding will stop. So coming to the definitive management, three situations can occur. So bleeding stops, but no diagnosis can be made on endoscopy, and bleeding continues. So first is bleeding stops and diagnosis is made. So it is mostly acute erosive gastritis or duodenal ulcer or gastric ulcer or esophageal varices. So diagnosis is made or can be made and bleeding stops. Suppose there is acute erosive gastritis, so it is treated with antacid, H2 blockers or PPI, proton pump inhibitors. If it is duodenal ulcer or gastric ulcer, if we see visible vessels on endoscopy, so sclerotherapy should be used, or endoscopic coagulation or operation. These are the options. And if we see no visible vessels, then simple medication is sufficient in the form of H2 blockers or PPI. If we see the diagnosis is esophageal varices, then options what we have is sclerotherapy, banding or clipping. So thus we manage such patient, that is bleeding stops and diagnosis is made. So bleeding stops and no diagnosis on endoscopy. So here in this group of patient, so vital monitoring should be done. Nasogastric tube should be in situ for some time, and through that nasogastric tube you can give antacid to neutralize the acid, or intravenously we can neutralize the acid by giving the proton pump inhibitors. And if you see after some time that there is no bleeding, then the nasogastric tube should be removed and the neutralization of acid should go on. And feeding should be allowed after 72 hours of arrest of bleeding. Then, if required, definitive surgery is planned electively. In some patients, bleeding is secondary to coagulopathy. The most important causes are liver disease and inadequately controlled warfarin therapy. So coagulopathy should be corrected with fresh frozen plasma, that is FFP. So lastly, we have this group that is bleeding continues in spite of everything. So in profuse bleeding, insertion of Sengstaken-Blakemore tube may be carried out before an endoscopy in patient with known esophageal varices and uncontrollable bleeding. So beforehand, if the diagnosis is esophageal varices, we know it. Then, and if the bleeding is profuse, then in those patients, Sengstaken-Blakemore tube is inserted and the balloon is inflated. So that will create a compression around the bleeding vessels, and temporarily bleeding can stop. And side by side we can use IV terlipressin or vasopressin that helps many a time in arresting the bleeding. Once bleeding is less, definitive management with either sclerotherapy or endoscopic banding or coagulation is to be carried out. So this is the tube, SB tube. So this is passed into the stomach and it is inflated. So it has a balloon for the funnel region and it has a balloon for the lower esophagus. So thereby it creates a tamponade effect around this region, and this will take care of the esophageal as well as the gastric varices. So operative treatment. So coming to the indications of operative treatment: elderly patients, massive blood loss, so that is loss of 1.5 to 2 liters of blood, or blood loss causing fall of hematocrit level below 25%, or after initial stabilization if blood replacement is more than 1 liter per day. So these patients are to be kept for operative treatment. Other indications are hemodynamically unstable patients, massive rebleed, coexisting perforation with bleeding, bleeding beyond 48 hours, or shortage of compatible blood. So these are the indications for surgery. So duodenal ulcer, the most common site of bleeding from a peptic ulcer is the duodenum, and usually from a posterior wall ulcer of the duodenal bulb. So the bleeding comes from the gastroduodenal artery or one of its branches. So the duodenum is fully mobilized. This should be done before the duodenum is open, as it makes the ulcer much more accessible and also allows the surgeon's hand to be placed behind the gastroduodenal artery, which is commonly the source of major bleeding. So after mobilization, the duodenum and usually the pylorus are open longitudinally, anteriorly, as done in a case of pyloroplasty. So this is the incision 3 centimeter in the duodenum, 3 centimeter in the pylorus. Longitudinal incision is given and the area is open. So this allows good access to the ulcer, which is posterior ulcer, or superiorly it can be found. So it is the vessel within the ulcer that bleeds. So sutures should be placed above, below, and should encircle the bleeding gastroduodenal artery. And after arresting the bleeding, the pyloroplasty should be done. That area should be closed with interrupted sutures in a transverse direction. So once the suture, this is ligated above, below, and across. So after securing the bleeding, it is closed by giving interrupted sutures. And this is to be followed by bilateral truncal vagotomy if the general condition of the patient is good. If the patient's condition is not good, simply arresting the bleeding is sufficient. If the general condition is good, then bilateral truncal vagotomy should be included. Gastric ulcer. The principle of management of bleeding gastric ulcer is essentially the same. So gastrotomy, is done. The stomach is open at the appropriate position anteriorly, and the vessel in the ulcer are underrun. If the ulcer is not excised, then a biopsy of the edge needs to be taken to exclude malignant transformation. And after taking the biopsy, the ulcer can be approximated. So other options are partial gastrectomy with Billroth 1 anastomosis, vagotomy with antrectomy, occasionally splenic vessel ligation with splenectomy can be done. Coming to further management, so during discharge, patients should be prescribed with the anti-Helicobacter pylori therapy. And after anti-Helicobacter pylori therapy, PPI should be given for 6 to 12 weeks. Follow-up with endoscopy should be done after 6 to 12 weeks. So next we have DIEULAFOY'S disease. So DIEULAFOY'S disease is a gastric arterial venous malformation. This lesion can be a problem for both endoscopists and pathologists to locate and identify. Bleeding as a result of this malformation is one of the most difficult type of upper gastrointestinal bleed to treat. DIEULAFOY'S lesions are characterized by a single large tortuous small artery in the submucosa which does not undergo normal branching, or a branch with caliber of 1 to 5 mm, which is more than 10 times the normal diameter of the mucosal capillary. The lesion bleeds into the gastrointestinal tract through a minute defect in the mucosa, which is not a primary ulcer of the mucosa, but an erosion likely caused in the submucosal surface by protrusion of pulsatile arterioles. The lesion itself is covered by normal mucosa, and when not bleeding, it is invisible. And during endoscopy, if it can be seen bleeding, all that may be visible is profuse bleeding coming from an area of apparently normal mucosa. So usually we can't see, but if luckily we see on endoscopy, so the picture will be profuse bleeding from a area which is apparently having normal mucosa. If the lesion can be identified endoscopically, there are various means of dealing with it, including the injection of sclerosant and endoscopic clips. If it is identified at operation, then only a local excision is necessary. Next topic is portal hypertension and portal gastropathy. Coming to portal hypertension, the management of bleeding gastric varices is very challenging. Fortunately, most bleeding from varices is esophageal and can be managed well by sclerotherapy, banding, or balloon tamponade. Sclerotherapy may be used for gastric varices, although this is technically more difficult. So bending can also be used here again with difficulty. The gastric balloon of Sengstaken-Blakemore tube can be used to arrest hemorrhage from the fundus of the stomach. Octreotide reduces portal pressure in patients with varices, and trials suggest that it is of value in arresting hemorrhage. So most surgeons prefer to avoid acute surgery on bleeding varices because of high operative mortality. So for this region, TIPS, that is transjugular intrahepatic portosystemic shunt, can be an extremely useful procedure, although technically difficult to perform and is performed by the interventional radiologist. So portal gastropathy, here the mucosa is affected by the increased portal pressure, and mucosa may exude blood even in the absence of well-developed visible varices. So the treatment here is same with portal hypertension. So portal hypertension overall is a big topic, so that will be dealt later on by different speaker. So this is the procedure which is done. It is TIPS. So here cannulation is done in the internal jugular vein, and through there we go to the hepatic vein. So this is the hepatic vein, and through the hepatic vein we cannulate the portal vein. So once this cannulation is done through the hepatic vein, so stents are placed through the hepatic vein to the portal vein. So this is TIPS. So a communication is established between the hepatic vein and the portal vein, so thereby reducing the portal venous pressure. So this is the treatment of choice nowadays to reduce portal hypertension. Next topic is aortic enteric fistula, which may cause bleeding. So it is to be considered in any patient with hematemesis and MELAENA where the exact diagnosis could not be made. Most of the time bleeding is not massive, but rarely it can bleed massively. It is occasionally seen in untreated case of aortic aneurysm. A well-performed CT scan will allow proper diagnosis, and if diagnosis is made, patient should be managed by expert vascular surgeon. Thank you.